very typically a renal or a nephrologist perspective. And of course, we'll be talking about physiology too. But I hope I'll be able to link it to the clinical aspects, because only when you understand physiology can you understand the pathophysiology, and can you understand how to approach and treat any condition for that matter. So I've titled this lecture as Renal Physiology, What Makes the Neonate Different. And I don't think I need to tell the neonatologist that the physiology of every organ system in the neonate is evolving, and the kidney is no different. So again, a very renal perspective here, looking at what happens in the glomerulus. All nephrologists in the group, if there are any, would understand that we always like to compartmentalize the kidney into glomerulus, tubules. It makes it's easy to understand things, and of course, looking at the applied aspects. So meet the fetal kidney. No, don't be surprised. This is actually the placenta, which takes care of most of the excretory and the acid-base balance of the fetus. So what does the fetal kidney then do? The fetal kidney produces urine, which is a very hypoosmolar or very low osmotic fluid, which contributes somewhere around the second half of the second trimester and the third trimester to about 70 to 80% of the amniotic fluid. And we all know the many functions of the amniotic fluid and its importance. So other than this, what does the kidney actually do? It also produces hormones like 1,25-dihydroxy-D3 and erythropoietin, which have important roles as well. So the major excretory function is taken care by the placenta until birth, when the placenta is then detached from the newborn. So what are the key renal developmental milestones? Before we understand physiology, we need to understand what the anatomy or the development and embryology is. I will just touch upon it briefly because it's a whole talk by itself. We know that, like most major organ systems, the kidney also appears very, very early in the embryonic period itself. By about 5 weeks, the major part of the mesenchyme that is going to form the kidney, that is the metanephros, appears. The primitive glomerulus, which is the filtering unit of the kidney, develops by as early as 10 weeks. And as soon as it's formed, it starts producing urine. So by 11 weeks, fetal urine is being produced. But it is only by about after 20 weeks, when the skin is keratinized and the urine production increases, that it contributes in a large way to the amniotic fluid. Branching morphogenesis, which is embryon, again, a fetal developmental structure where there are multiple iterations of the collecting system from which new nephrons appear, happens at around 22 weeks. And nephrogenesis is complete by 36 weeks, which means that after 36 weeks of gestation, whether the baby is in utero or ex utero, no more new nephrons are formed. And this is one very important point to remember, and we'll be coming to that over and over again through this talk. So again, quickly about the development of the kidney, there are three important terminologies to understand. One is the reciprocal induction of the metanephric mesenchyme and the ureteric bud, which means the part of the mesenchyme which forms the kidney and the collecting system both reciprocally induce each other to develop. So abnormalities of one almost always lead to the abnormality of the other. So if you have an abnormal kidney, always look for a urinary tract abnormality, and if you have an abnormal urinary tract, look at the abnormal kidney. Mesenchymal epithelial transformation, which is a part of the development and maturation, and branching morphogenesis is the multiple iterations, which goes in a centrifugal manner. So it goes from the medulla towards the cortex, and the newest nephrons are present in the cortical aspects of the kidney. This is a busy slide, but it shows you the multiple factors that are involved in the development of the kidney. And needless to say, there can be multiple disorders that can be associated with abnormalities of the kidney. The most important are those which induce the ureteric bud and the metanephric mesenchyme. Again, like most other organ systems, it's not just what is happening within the fetus, but also what is happening in utero and in the mother, including the maternal diseases like diabetes or hypertension, the maternal nutrition, genetic conditions, social factors, all have a great impact not only on the birth weight and gestational age of the neonate, but also on the nephron number. And again, we'll be dealing with this subsequently. So let's start with nephrogenesis or the nephron numbers. We said that the nephrons start as early as 10 weeks. But only from about 20 weeks onwards, there is an exponential increase in the number of nephrons, and nephrogenesis is complete by about 36 weeks of gestational age. Beyond that, there are no new nephrons formed. There's also a linear increase in the renal mass as the gestational age advances. So irrespective of whether like when a baby is born preterm, definitely we can understand that there are fewer nephrons, but also important to remember that nephrogenesis or the number of nephrons correlate with the birth weight. So even if a baby is born at term, but of lower birth weight, about 25,000 less nephrons per 100 grams of birth weight. So you can imagine if the baby is 1 kg less than the normal, there will be so many less nephrons. And this is what will have to last for a lifetime. What happens in the preterm? If a baby is born at 32 weeks, we said nephrogenesis goes on till 36 weeks. So do the preterm neonates develop new nephrons? Yes, they do. And nephrogenesis can continue up to 40 days of postnatal life. But what is important to remember is studies in both humans and in animal models have shown that though the preterm kidneys achieve a normal kidney size subsequently, they always have a lower number of nephrons, and even those nephrons which are developed later after birth are highly abnormal. So they have done autopsies, biopsies of autopsies, and found that the cortical nephrons, the most superficial, are abnormal or not normally developed. So the best time for nephrogenesis is in utero, and the ex utero environment is really not conducive. In the low birth weight baby, there is low nephron endowment because there is a great correlation with the birth weight, and they are at risk of hyperfiltration injury subsequently. So that is about the nephrogenesis. Let's go on to what happens actually to these nephron units, looking at the glomerular physiology. Let me take you back to your physiology classes, and you can, if you can recollect, blood flow in any vessel is directly proportional to the difference in the pressure between the artery and the vein, and inversely proportional to the resistance provided by these vessels. And in the kidney, which has a unique vasculature, the resistance is provided by the arterioles, that is the afferent and the efferent arterioles, in between which is the glomerular capillary tuft. And what is important again in the resistance is that it is inversely proportional to the 4th power of the radius, which means that a small change in radius of the vessels can cause a huge change in resistance. And the kidney is one of the organs which uses this principle to the maximum. So the glomerular filtration, a simple formula, or just logically, if you think about it, is a product of the single nephron GFR. That is the GFR of each of these nephrons and multiplied by the total number of nephrons. The single nephron GFR or SNGFR is influenced by the permeability of the capillaries. The S stands for the surface area. And you know this very well, the cylindrical model where we talk about the hydrostatic pressure within the glomerular capillaries, which is determined by the systemic blood pressure and the renal blood flow, which promotes filtration. The osmotic pressure within the glomerulus, mainly attributed to albumin, prevents filtration. Similarly, in the Bowman's space, the Bowman's capsule hydrostatic pressure opposes filtration, and the very negligible osmotic pressure within the Bowman's capsule favors filtration. So since this is negligible, this is removed from the equation, and this is what you have. So the intrinsic regulation occurs, which is called autoregulation, like all other major organs, takes place by the myogenic reflex as well as the tubular glomerular feedback. But there is a lot of extrinsic regulation as well by a delicate balance that is maintained between the vasoconstrictors and the vasodilators. Now, this is important in older children and adults, this is important in situations where the renal blood flow or the GFR is compromised. Say, for example, a child with dehydration, where there is a low intravascular volume and the kidney is trying to maintain its blood supply. But in the newborn, and in the fetus as well, the renal blood flow and the glomerular filtration are very low. So the glomerular filtration in these babies is maintained by a very delicate balance. The major players here are angiotensin, which mainly acts on the efferent arteriole. If I just go back, you can imagine if the efferent arteriolar pressure increases and the efferent arteriolar pressure is normal, there is increased glomerular filtration. Whereas if the afferent arteriolar pressure increases and there is constriction here, the glomerular filtration reduces. So the angiotensin acts on the efferent arteriole and maintains the glomerular filtration. So also the renal sympathetic activity and endothelin. Adenosine is not very important physiologically, but in pathological conditions, adenosine causes constriction of the afferent arteriole. And we'll see this in a few case scenarios. Now, if we have significant vasoconstriction, that will lead to a reduction in GFR and renal blood flow. So that has to be counteracted by vasodilators, and the most important ones are prostaglandins and nitric oxide. So you can imagine what the consequences of a tight regulation of GFR with these vasoconstrictors and dilators would be, especially keeping in mind the drugs that may be used to inhibit these agents. So we said that renal blood flow, we said that the kidney doesn't really have an excretory function, so it doesn't require a lot of blood. So naturally, it gets very little of the cardiac output, which is only about 3%. If you recollect, in the adult kidney, the kidney receives about 25% of the cardiac output. So it's almost 1/10 of it. And this is because of the high vascular resistance in the kidney maintained by the renin-angiotensin system. And there are also, to counteract and maintain some level of renal blood flow, there are high levels of prostaglandins as well. So use of ACE inhibitors or prostaglandin inhibitors, that is NSAIDs, during pregnancy can have very deleterious effects on renal blood flow. The fetal GFR as well is very low because the renal blood flow itself is very low. And even at term gestation, it is about 5 ml per minute. And it is maintained by this balance of vasoconstrictors and dilators. Immediately after birth, there is a significant change that happens in the circulation, and the GFR increases to about 20 to 30 ml per minute in the term newborn. It then rapidly increases by about 2.5 to 3-fold in the first month. So by the end of the neonatal period, the GFR is almost 10 times that in the fetus, and it achieves about 90% of the adult GFR by 1 year, and the adult values of GFR are achieved by 2 years. How does this GFR mature? So one most important factor is the increase in cardiac output. We know the transition from fetal to neonatal circulation, and the cardiac output that is given to the kidney increases to about 10%. There's also an increase in the systemic blood pressure, which means there is an increase in renal blood flow, which doubles by about 2 weeks and reaches adult values by 2 years. So let's go back to our equation. Total number of nephrons do not increase after birth. So the only way to increase the total GFR is to increase the single nephron GFR. And in that, the most important factor is the glomerular hydrostatic pressure, which is maintained by the systemic blood pressure and the renal blood flow. The auto-regulation is very well developed in a normal newborn, but of course it is set at blood pressures that are normal for the neonate. So let's look at some of the applied aspects here. A preterm baby has PDA, and you now know that indomethacin, ibuprofen are no longer used because of the risk of AKI. So how does indomethacin cause AKI? So I think we've already discussed this, that there is a tight balance of vasoconstrictors and dilators. So NSAIDs and ACE inhibitors, both in the fetus as well as in the newborn, disrupt this balance and reduce the GFR. All of you know very well that in neonates with perinatal asphyxia, a single dose of theophylline has been, there is evidence to show that it reduces the risk of AKI. So how do you think theophylline works? So in the presence of hypoxemia, there is increased intrarenal adenosine. And we already saw that adenosine is a very strong afferent arteriolar constriction, which reduces both the renal blood flow as well as the GFR. And theophylline, being a adenosine receptor antagonist, prevents this vasoconstriction and maintains the GFR. So it reduces the risk of AKI. So having looked at how the glomerulus is in the fetus and how it matures, let's go back to the tubules. Now, very quickly on a recap of the tubular physiology, because without understanding this, it's very difficult to understand what happens. I'll try to simplify it as much as possible. The proximal tubule we know is the most active part of the nephron, and it has most of the substances are large quantity of most of the substances are reabsorbed in this segment of the nephron. About 70% of the sodium in water, and sodium is reabsorbed as a co-transport mechanism with several substances like glucose, amino acids, and phosphates. But all these are secondary transporters, which are mainly maintained by an electrochemical gradient created by the sodium-potassium ATPase. So this is the main channel that maintains the function of the proximal tubule. It also is important for bicarbonate reabsorption by the sodium-hydrogen exchanger and the carbonic anhydrase enzymes. And let's look at why all this is important to know. The tubular function of phosphate reabsorption is maintained by three things. One is the GFR, which we already know is low in the newborn, the sodium NAPI channels, sodium phosphate channels, and it's hormonally regulated by PTH, which is a phosphaturic hormone. So what happens in the newborn that is different? We know that newborns have a high fractional excretion of sodium, not only because of the low reabsorption in the proximal tubule, but also in the subsequent parts of the tubule, which we will discuss. Preterm newborns and some term newborns in the very early phase may have glucosuria because of a poorly developed glucose transporters. There's low excretion of phosphate and low sensitivity to the hormonal regulators. So low excretion of phosphate is actually beneficial to the newborn because the newborns require a positive phosphate balance for growth to occur. What happens after birth? After birth, one, of course, is that the GFR increases. And we know a physiological mechanism called the glomerular tubular balance, which means as the GFR increases, the tubular reabsorption also increases so that you don't filtrate all the plasma. So as the GFR increases, the normal physiological mechanism is to increase tubular reabsorption so that the total urine output remains the same. So this, of course, is active, but there's also a significant increase in the length of the proximal tubules that happens. There is maturation of the sodium-potassium ATPase, which we discussed is the most important channel. And this is brought about by the maternal and fetal steroids, which are in high levels, especially in the perinatal period. And also sometimes the steroids that are given, during the, like if there is an anticipated preterm birth, the thyroid hormone also plays an important role in the maturation of the sodium-potassium ATPase. In addition, so the maturation happens by about 2 weeks. So the proximal tubular function really increases significantly in the first 2 weeks. There is an increased expression also of the sodium-hydrogen exchanger and the glucose transporters. So the fractional excretion of sodium, which was high, it may be up to 3% in term newborns and about 5% in preterm newborns, reduces to the normal that we say in adults or in older children of less than 1% by 1 month of age. Similarly, fractional excretion of phosphate slowly increases to about 6 to 7% by week 1. But since we need phosphate for positive phosphate balance, it normalizes only by about 2 years with the parallel to the maturation of the GFR. Let's go to the next segment, that is the thick ascending loop, which has the sodium-potassium 2-chloride channel, which is important for sodium reabsorption, and the ROMK, which basically maintains the gradient for sodium reabsorption. And most importantly, it is the diluting segment of the nephron. The cortical collecting duct here again has important channels, the epithelial sodium channel, which is important for sodium reabsorption, and the ROMK for potassium excretion. And it is this part of the nephron which plays a major role in potassium excretion and is influenced by aldosterone. The medullary collecting duct has ADH, of course, requires ADH to be present, acting on its receptor, the aquaporin channels, which will reabsorb water. What is also important is that there has to be a medullary osmotic gradient for this system to work. So having looked at the physiology, how is it different in a newborn? what is surprising is, though the entire tubules are not mature at birth, what is present is a normal diluting ability of the nephron. And this is important because the newborn is going to be on a feed of a very dilute substance, that is breast milk. So the ability to dilute the urine is a very important aspect for the newborn. A lower potassium excretion because of the reduced number of ROM-K and Maxi-K channels, which develop later on, and also a poor sensitivity to aldosterone. And this is again important because a positive potassium balance is required for growth. A poor concentrating capacity because of resistance to ADH, reduced number of aquaporin channels, and also the cyclic AMP, and low sensitivity to the hormonal regulators. So what happens after birth? There is an increase in the number of channels, especially the flow-activated Maxi-K channels, and concentrating capacity is achieved up to adult levels by about 2 years. So we looked at what are the developmental milestones. Let's look at what are the postnatal milestones. So we already said maximal diluting capacity is already present at birth. The renal blood flow and the GFR double in the first 2 weeks, and they come to normal adult levels by about 2 years. Phosphate excretion again comes to the normal adult level by 2 years, and maximum concentrating capacity also is achieved by about 2 years. A few applied aspects again. A preterm newborn with AKI has a urine output of 3.5 ml per kg per hour, which is like a good normal urine output despite a very high creatinine. Why do you think this happens? So it is not uncommon to have AKI in the newborn, which is mostly non-oliguric. There are very few conditions which have oliguric or anuric AKI, and this is because of the poor concentrating ability of the preterm kidney. So even when the GFR is low, the kidney is not able to concentrate urine, hence they remain non-oliguric. Your diligent intern is collecting reports of a 28-week-old newborn, and he's alarmed by the abnormal reports. The creatinine of the baby is 1.1, the potassium is 6.3, the bicarbonate is 16.5, and the urine osmolality is only 500. So he asks you why all this is happening, though the baby is relatively stable. So the explanation here, of course, the physiological basis would be that creatinine on day 1 is a reflection of the maternal creatinine, and it doesn't reflect the neonatal kidney function. Tubular immaturity in the preterm newborn results in poor potassium excretion, hence a higher level of potassium, and a poor bicarbonate reabsorption, and newborns have a poor concentrating capacity. So putting all this together, we know that the normal values for potassium, bicarbonate, and urine osmolality are different. And we know that creatinine, or assessment of creatinine as a marker of kidney function, has to be assessed in the background of the clinical situation and not just the value per se. The urine output, we know, is, though in the fetus it is not important from the excretory point of view, starts at a very low rate of 6 ml per hour at 20 weeks, and it increases almost 5 to 10 fold by about 40 weeks term gestation to about 40 to 60 ml per hour. But it is hypotonic. After birth, there is an oliguric phase for 24 to 48 hours and followed by a diuretic phase. Now, this is another question for the residents and trainees. Exposure to this teratogen in early pregnancy causes this histological picture of the kidney. I'll give you a clue if you're not too familiar, that the tubules are not well developed or are absent here, some of the proximal tubules, and this is the phenotype of the baby. And exposure in late pregnancy or in the neonate causes oligoanuric AKI. If anyone wants to put the answer in the chat box, you can do so. The answer is ACE inhibitors or angiotensin receptor blockers. It causes in early pregnancy, because angiotensin is not only important for maintaining the GFR physiological, the functional aspect, but also important for the development, normal development of the nephron and its vasculature. So abnormal or blocking this caused by use of ACE inhibitors causes a condition called renal tubular dysgenesis, where the tubules, the proximal tubules, are not well developed, and results in severe oligohydramnios, resulting in the Potter's syndrome. And of course, in late pregnancy or in the neonatal period, it can cause AKI. Very quickly on the kidney function, I'm sure it will be discussed subsequently. Serum creatinine reflects maternal creatinine in the first few days. We know a lot of physiological changes are happening in the first 2 weeks. So the creatinine only normalizes to about, comes to the normal levels in term neonates by about 1 to 2 weeks. And it may take much longer in the preterm, up to 3 to 8 weeks. If you see this picture, you can see that in the preterm, the blue line, there is a rise in the initial few days followed by a fall. And this is because there is increased tubular reabsorption of creatinine in the immature tubules of the preterm, and it's should not be attributed always to a AKI. So you need to see the age appropriate creatinine levels before interpreting this. We know the disadvantages of creatinine, that it is transplacentally transferred. It is dependent on the sex and the muscle mass. Tubular reabsorption and secretion will either overestimate or underestimate the GFR. Opposed to this, we have cystatin, which is completely filtered and reabsorbed. There is no transplacental or very little transplacental transfer, and it's not dependent on the muscle mass. So there are enough studies to show that it is a good indicator for GFR in the newborns, but it is still not very prevalent in clinical practice. Exogenous markers are, of course, mostly used on a research basis and not in clinical practice. Inulin is the gold standard, but is no longer used. Iohexol is most commonly used. And you can see these, the inulin clearance, which shows that the GFR in the preterm neonate is much lower than in the term, and it slowly increases as the postnatal age progresses. But even in the preterm, like at 4 months, the GFR is much lesser than in the term newborn. These problems of prematurity and low birth weight have long-term consequences as well. So we've discussed that during nephrogenesis, there are low nephron numbers, abnormal and enlarged glomeruli, and risk of dysfunction. In addition, the disadvantaged preterm or the IUGR kidney is also exposed to other risk factors like AKI due to multiple reasons, nephrotoxic medications, and hyperoxia, which may hamper the postnatal nephrogenesis and development as well. And in older children and adults, the nutrition and lifestyle predispose or add to the insult that is already there to result in reduced kidney volume, salt-sensitive hypertension, hyperfiltration, proteinuria, a low renal functional reserve, and a high risk of chronic kidney disease. Important here to say that these children who are born preterm require monitoring of their kidney function and kidney health throughout life. So a few quick takeaways from this topic. The placenta acts as the fetal kidney by taking over its excretory function. Nephrogenesis is complete by 36 weeks of life, and no new nephrons are formed thereafter. Or transition requires maturation of both the glomerular and the tubular functions. Increase in renal blood flow and an active renin-angiotensin system maintains the GFR in the fetus and in the newborn. Tubular function, there is an increase in tubular transport, mainly by the maturation of the channels, hormonal sensitivity, and the concentrating capacity of the kidney finally increases. Prematurity and low birth weight have both short-term and long-term implications. Thank you.
Thank you, Nivedita, for such a wonderful lecture, from taking us, back to physiology and then back to the bedside. So thanks very much for this. And you simplified it so well. And I'm so glad that we are recording this meeting, because I'm sure many of us would like to revisit it later when we have our questions. So thank you again. And let us see if we have any questions in the chat. There are none in the chat or in the Q&A. But I would request the participants to please use the expertise of our speakers and panelists to post your questions. And I'm sure they won't mind if it is not related only to the topic, and it could be related. So I have one question here from Lekha Parekh. What urine output should be targeted for a term baby, day of life 1, who is in shock and requiring inotropes? When should we consider PD? So
we all know that neonates are oliguric on day 1. So I don't think there is a cutoff urine output that we should target. But what we need to see is the intake output balance that needs to be maintained. Definitely a baby who's in shock, maybe asphyxia or any other condition, would be oliguric in excess to what is normally expected. But the indication for PD would not be just the oliguria. There would be a lot of things to consider. One is, of course, like the metabolic parameters, whether the baby is able to maintain the acidosis, potassium balance, and all those things. In addition, you would also look at the urine output, the percentage of fluid overload, the weight gain that this baby is having, the cardiovascular function. So all these need to be taken into account when we consider dialysis.
Thanks, Nivi. There's one more. I don't know. I think it's more of a comment. Dr. Santosh Kudbe says that we see hydronephrosis, that function improves after surgery up to 2 years in PUJ obstruction cases, and always, I'm not sure, throughout. Dr. Santosh, do you want to ask your question? You can unmute and ask your question.
I don't think attendees can unmute. Dr. Santosh, try raising your hand. Maybe I can unmute you.
Go ahead, Dr. Santosh. Please go ahead.
Ma'am, actually, yeah.
Please go ahead, Dr. Santosh.
In small neonates and early infancy, we see PU junction obstructions, and the function is less in some of these babies. And it improves after surgery, madam. And we have been always thinking that the nephrogenesis exists 2 years after birth. Is it true, madam? Or
so I think some functional improvement will happen because of the relief of the obstruction itself. But it is very well known that nephrogenesis does not happen after 36 weeks of gestation. And even in preterms who are born prematurely, say, like I said, maybe 30 weeks or 32 weeks, it only happens for the next 6 weeks, about 40 days after birth. And there also they have found that it's related to the post-menstrual age rather than to the postnatal age itself. So it's mainly that maximum nephrogenesis of normal nephrons are developed best in utero. Ex utero, there is some, like these studies have shown that there is about 2 to 20% increase in the nephron numbers. But this is only for the first 6 weeks. So there is no nephrogenesis that is documented beyond that. And like I said, even in preterms who have new nephrons developing, there are biopsies that have shown that they are not normal glomeruli.
One more question is on late onset hyponatremia in premature babies. When does it occur? How does it resolve?
So usually it is seen in the first or second week of life. Again, here, like we said, by 36 weeks or by term gestation, roughly, the dilutional capacity of the kidney is I'm talking mainly from the renal point of view. There are intestinal reasons also for sodium loss, but from the renal point of view, in the preterm newborn, though we say that dilutional capacity develops first, in some preterms, it may extreme preterms, the dilutional capacity also may not have been developed, as well as the high salt losses that we have already said, and the low GFR. These are all the major contributing factors. So many newborns, the preterm newborns, require salt supplementation. Usually it lasts for about a few weeks.
Next one is on how to interpret and use urine-specific gravity in daily preterm care.
I don't think there is any actual role of doing urine specific gravity per se in, like we do know that there were a lot of urinary indices that we use to distinguish between pre-renal and intrinsic renal AKI. We no longer use them, but there is no role for using specific gravity in daily care of the newborn. What we need to understand is that they have poor concentrating capacity, so they are at increased risk of excessive free water loss, and we may need to make sure that their intake output is balanced by, in a routine preterm care of a normal preterm who's otherwise just growing, maybe just monitoring of weight, assessing for dehydration, and ensuring adequate feeds would be the way to go.
Yeah, so a lot of questions coming up. So what I would do now is to restrict it to physiology questions, and
Sure.
AKI questions we'll take it during the panel discussion. So there's a question on interpreting creato 1.5, and I guess it is on day 1 of life by Gayatri. So this in a 36-weeker. So quick responses now, Dr. Nivedita.
So I think the creatinine on day 1 is a reflection of the maternal creatinine. And of course, if it is extremely high, you would consider it in the context of the clinical scenario. But what would be important is to see what the clinical scenario is and look at the trends of creatinine.
Dr. Bharat has asked, do you have any suggestion for a bundle of care? Because 40 days of postnatal life is all we have.
Yes, there is no like guidelines of bundle of care, but many of these review articles do mention hyperoxia, careful use of nephrotoxic medications, especially antibiotics, aminoglycosides. All these are commonly used drugs in the newborn, NSAIDs, maintaining hydration, preventing AKI by different methods. So these are the important things to be done in the first 40 days of life.
There's one more question, Dr. Bharat Sukija's question. We'll take it up later because it is to do with the AKI. And so Dr. Santosh is asking you and Dr. Kanishka, does renal dysplasia improve with any conservative treatment or medicines?
So the term dysplasia itself means that the tissue has not developed normally. So obviously there is nothing that we can do to normalize it. Like even for the previous question which was asked, these children may have so-called normal GFR for some time or a normal creatinine for some time. And this is because of the hyperfiltration or the overfunctioning of the remaining nephrons. So they carry on for some time, but decompensate after some time. So conservative management would be to ensure adequate growth, blood pressure control. If they are salt losers, to supplement salt, to make sure their metabolic parameters are maintained. So this would be the conservative management, but we cannot change the structural abnormality or the